Okay, we will start discussing our slides for the credit, and we will start with the first one, Leukoplakia. When we are talking about any pathological processes, first of all, you should tell the definition of this process. Leukoplakia is excessive keratinization of a non-keratinizing squamous cell epithelium. That means that sometimes we, in normal conditions, see only non-keratinizing squamous epithelium, for example, on mucosa, here in the mouth. And in pathological conditions, in unknown etiology, we sometimes see excessive keratinization. And you can see the difference between keratinizing and not keratinizing squamous cell epithelium. In non-keratinizing squamous cell epithelium, blood vessels give characteristic reddish appearance of the mucosa. In areas with keratinized squamous cell epithelium, we can see thick white spot. In histology, we can see epidermis of the squamous cell epithelium, multilayered, and under epidermis there is derma. On the surface of epidermis, we can see a lot of pink keratin. This keratin tells us that there is excessive keratinization here. Leukoplakia comes from Greek language. Leuko means white, plakia means plaque. Why is it dangerous? Leukoplakia is obligatory precancerous condition. That means that if the doctor will do nothing with this, it will become cancer 100%, maybe in 5 years, maybe in 10 years, but it will be. So dysplasia looks different. Here you can see how dysplasia in squamous cell epithelium looks like. And dysplasia is characterized by hyperplasia of the basal cell layer, a lot of mitosis. Here you can see mitosis, hyperchromatic nuclei, sometimes nucleoli can be seen in nuclei, and basal cell layer consists almost full thickness of epithelium. That means that it proliferates very quickly. So dysplasia is the precancerous step. The next step of dysplasia is invasive tumor. Here we can see also high magnification, a lot of layers of epidermis and keratin on the surface. The next specimen is fatty liver. There is a synonym for this condition. It's steatosis or parenchymatous fat dystrophy. Steatosis is characterized by the accumulation of the fat in hepatocytes. Here we can see central vein in the center of the liver lobule. On the periphery, you can see normal hepatocytes, and on the right, on the left, in upper down, you can see a lot of hepatocytes which contain a lot of white droplets. These white droplets are fat. Fats don't stained by hematoxylin and eosin. On hematoxylin and eosin, they look transparent. We should use special histochemical stain, which is called Sudan 3 or Sudan 4, to reveal fats in tissue. And what else? Here, you should know that there are two types of steatosis, macrovesicular and microvesicular. Macrovesicular steatosis has big droplets of fats in the cytoplasm of hepatocytes, which push the nucleus towards the periphery of the cell. And you can see that almost all volume of cytoplasm is filled with this fat, and nucleus is at the periphery. Microvesicular dystrophy is different because here we can see that nucleus stays in the center of the hepatocyte, and droplets of fat surround hepatocyte nucleus in the hepatocyte. In this situation, droplets of fat are situated not in the cytoplasm but in mitochondria. This process has different etiology and it's more severe. As far as you remember from biochemistry, Krebs cycle starts with acyl coenzyme A, which is a result of metabolism of fatty acids. So when this process is blocked, we can see accumulation of fatty acids in mitochondria. In these situations, patients very quickly develop acute liver insufficiency. On the gross specimen, you can see this picture. Liver is enlarged, has diffuse white, not white, yellow surface. It's smooth. Here you can't see any nodules. There is no cirrhosis here. So the next slide. The next slide is amyloidosis. Amyloidosis is abnormal accumulation of the proteins. Not abnormal accumulation of the proteins, but accumulation of abnormal proteins. Amyloid is abnormal protein, and this is mesenchymal parenchymatous dystrophy. So here we use special stain to reveal amyloid masses. It's called Congo-red. Here you can see accumulation of amyloid in the glomeruli, also accumulation of amyloid in surrounding the blood vessel, and sometimes we can see amyloid masses in the basement membrane of the renal tubules. On the next slide, you can see possible mechanisms of amyloid development. For example, there is primary amyloidosis. Primary amyloidosis is characterized by malignant transformation of plasmacytes. Normal plasmacytes produce immunoglobulins, and in amyloidosis, they undergo malignant transformation and produce not normal immunoglobulins, but these light chains of tumor cells. These proteins are primary amyloid, L-amyloid, due to chemical composition. There is also secondary amyloidosis. Secondary amyloidosis usually can be seen in patients with chronic inflammation, because in periods of activation of this inflammation, macrophages produce a lot of interleukins 1 and 6, which stimulate hepatocytes, and in their turns, hepatocytes produce a lot of SAA protein, which then is converted in AA amyloid. And there is also one more type of amyloidosis, hereditary amyloidosis, which is caused by mutations in different genes. For example, transthyretin mutant protein, which also can be accumulated in different tissues. Here you can see also high magnification of the slide. One more time, amyloid is red here, and here also in the blood vessel. Additional way to reveal amyloid in the tissue is a polarization, because in polarized light, it's a special mode of microscopy. We will see amyloid on the slide stained by Congo-red as apple green birefringence. Very beautiful staining. Additional way to prove that this is amyloid. Grossly, we can see amyloidosis, for example, here in the kidney, as accumulation of substance which makes surface of the kidney wax-like, yellowish, and kidney looks edematous, but it is not. It looks like edematous just because accumulation of amyloid. We can call it also big white kidney or big fat kidney. And usually these patients develop also nephrotic syndrome. The next slide is a nutmeg liver. So nutmeg is more related to the gross appearance of the specimen. Here you can see nutmeg like it exists in the nature, and the cut surface of this nutmeg is really similar to liver in this condition. So here I can tell for the gross specimen that this condition can be observed in patients with chronic heart insufficiency, and you should also be more precise and to tell insufficiency of which ventricle. In this condition, it is insufficiency of right ventricle, because right ventricle pushes the blood into the small blood circulation, and when it can't do this, so we can see increase of venous blood pressure in the big blood circle, and that is why in the system of central vein we can see that erythrocytes go out of the sinusoids into connective tissue in hepatocytes, and we can see hemorrhage, which surrounds the central vein. At the periphery of the liver lobule, we can see hepatocytes here. They look normal, but sometimes they develop steatosis because of hypoxia. And for example, here we can see intermittent zones of brown color and yellow color. So brown color we can see because of these zones of hemorrhages, and when erythrocytes are eaten by macrophages, we will see hemosiderophages also. And at the periphery of the liver lobule, we can see steatosis, which here looks as yellow color. The next specimen is lung hemochromatosis. So this is a condition which is related to the previous one because it also can be seen in patients with chronic heart insufficiency. And in this case, insufficiency of left ventricle, because when left ventricle can't push the blood into the big blood circle, it accumulates in the small blood circle. In this condition, we will see a lot of hemosiderophages. For example, here they have brown color because when erythrocytes are eaten, here you can see some rest of erythrocytes which are still in connective tissue, and here a lot of hemosiderophages. And the next very important moment is fibrosis of interalveolar septa, because in hypoxia, fibroblasts usually proliferate and produce a lot of fibers, and we can see proliferation of connective tissue here. So thick interalveolar septa and a lot of hemosiderophages are a clue to recognize this specimen. Here you can see hemosiderophages on more high magnification. You can see that macrophages here are still alive. That doesn't mean that this brown substance accumulates just somewhere in the tissue. It's situated in the cytoplasm of macrophages, which are normal cells with the nucleus and cytoplasm. On the gross appearance, this specimen has this is a lung, of course. This has very brownish, brown, orange, even parenchyma because of accumulation of a lot of hemosiderophages. And this is the most important feature, because also here you can see black spots of enterocosis, but enterocosis can be seen in almost all adult population. Also some bronchi, this is just cut surface of bronchi. This is also not something pathological, as sometimes students think. The next slide is myocardial infarction. First of all, the definition of infarction is really simple. Infarction is ischemic necrosis. So necrosis due to ischemia. And here we can see necrotic cardiomyocytes. We can be sure that they are dead because we can't see nuclei in the cytoplasm, nowhere. And the next feature of dead hepatocytes is loss of their striated architecture. Here it's not really good to assess because it really depends on your microscope. When your microscope is good, you can't see the striated muscles. When you have worse microscope, so you can't. So it's better to orientate on the nuclei. The dead zone of infarction normally is surrounded by the zone of perifocal inflammation. Perifocal inflammation is very important component because it's important to border dead piece of tissue from the live piece of tissue, and perifocal inflammation consists of neutrophils and lymphocytes mainly. Here you also can see that cardiomyocytes, which have diffused the eosinophilic cytoplasm and no nuclei. On the gross specimen, you can see white zones of necrosis and hemorrhagic spots which surrounds these zones of necrosis. You should remember that all infarctions are divided by color and by the shape, and myocardial infarction is a white infarction with hemorrhagic corolla. And it has a regular shape because coronary arteries have a regular type of branching. The next slide is liver infarction. So the same infarction is necrosis, ischemic necrosis of the liver parenchyma here, and it's a really rare condition because it's difficult to cause infarction in the liver. Sometimes it can be seen in operations when surgeons make some mistakes and cause liver infections by manipulations on the branches of hepatic artery, for example, or in patients with emboli, in septicopyemia, for example, bacterial emboli. Causes can be different, but usually infarctions in liver appear not in the whole liver, but in some small segments. And here we can see that hepatocytes, the same known nuclei in the cytoplasm, and this dead zone is demarcated by perifocal inflammation, which consists of mainly neutrophils there. Here you can see high magnification and a lot of neutrophils. The next specimen is mixed thrombus and atherosclerosis. On this slide particularly, you can see only the wall of the big blood vessel, and all this field of view is the wall. And here you can see smooth muscle. This is endothelial side, and all this field is atherosclerotic plaque. And here you can see some lipids, some proliferation of fibroblasts with fibers. Here, probably we have endothelium. Here we have smooth muscle of the artery. And here you can see as a continuous picture of this specimen, you can see big thrombus. So this thrombus is attached to the endothelium by fibrin. This is really important because there are also post-mortem clots which can be mistaken for thrombi by those people who don't know the difference. Post-mortem clots just freely lie in the blood vessels. They can be seen in autopsies. When it's thrombus, it's usually attached to the wall of the blood vessel, and it's usually have more rough appearance, not smooth appearance, but rough appearance. You can see that on the gross appearance, we can see aorta here with a lot of atherosclerotic plaques on different stages of development. Sometimes they are fibrotic plaques, sometimes adenomatous plaques, some were atheromatic ulcers, which development of thrombi. When these thrombi close the lumen of the blood vessels, in these patients there is ischemia, and sometimes they have pain and they need some therapy. The next specimen is liver hemosiderosis in hemolytic anemia. So we tell hemosiderosis and hemochromatosis in those people where we see excessive accumulation of iron. And here we can see iron in the cells of the liver. We use special stain to reveal iron. We call it co-muscle blue. And we can see that these spots are of diffusely blue color. Or in Russian, we can say Berlinska lazur, or what else? Yeah, I think that is it. It's very important to differentiate between hemochromatosis and hemosiderosis. Hemochromatosis is inherited conditions, and in condition it's characterized by very high level of absorbance of iron from the food. In this condition, it accumulates in the cytoplasm of hepatocytes. Hemosiderosis can be observed in patients with excessive, for example, hemolysis, like here. And in this condition, these dead erythrocytes are accumulated in macrophages, and in cytoplasm of these macrophages with destroyed erythrocytes, we can see a lot of iron. The next slide is metastatic calcification in myocardium. Calcification is excessive accumulation of calcium in the tissues, and there are three main types of calcification. You should be able to tell them when you answer me this specimen. So the first one is metastatic. We see it here. We see myocardium, and there are deposits of calcium here. They look very different to cells because they actually don't have any cytoplasms or nuclei, and we just see accumulation of these masses which look like small crystals or something. Other two types of calcification are dystrophic calcification and metabolic calcification. Very important that in metastatic calcification, we can see high level of calcium in the blood. All conditions which cause high level of calcium in the blood can end by metastatic calcification. For example, high levels of vitamin D, for example, abnormal intake of vitamin D, or hyperparathyroidism, or growths of bone, or myeloma which destroys bone. Dystrophic calcification doesn't characterized by high level of calcium in the blood because it's a very local condition. For example, in parasite bodies, in dead parasites, or in zones with dystrophy, for example, in atherosclerotic plaques. In these patients, level of calcium in the blood is not increased. And the last one, metabolic calcification. This is a disease with unknown etiology. And in this disease, we don't know etiology, and we don't see increased level of the calcium in the blood. Our next specimen is pigmented nevus of the skin. Nevus is a benign tumor of melanocytes, and here you can see stratified squamous cell epithelium. Here a small layer of keratinization, and in derma, exactly under epidermis, you can see nests of nevi cells. So this is the proliferation of melanocytes. Focally, you can see accumulation of melanin because the most important function of melanocytes is producing melanin, but not in each area, but these cells are still melanocytes. And in the lower part of the image, you can see that these islands become less and less prominent, and here we almost don't see these cells. This tumor is not malignant in comparison, in contrast to melanoma, which is a malignant tumor of melanocytes, and it can be inherited condition. And one moment, on the next slide, you can see a gross view of this on the high magnification, how we see these cells. On the skin, nevi can have black color. In gala nevi, they have gallo effect which surrounds them on the skin, white area surrounding. They can have really various appearance on the skin. The next specimen is endometrial adenomatous hyperplasia. So here we can see endometrium. Endometrium is composed of glands. These are glands, and in hyperplasia, which can be caused due to high level of estrogen, we can see cystic transformation of these glands. This, for example, this gland looks almost like normal. This gland is increased. They can have irregular shape and so-called back-to-back appearance, like here. They have very irregular shape and back-to-back appearance, and this condition in some percentage of cases also can undergo dysplasia and become cancer. When there is dysplasia and atypia in hyperplasia, later than hyperplasia, we can see hyperchromatic nuclei, signs of atypia in the cells, increased number of mitosis, etc. The next slide is bronchopneumonia, focal pneumonia. So you should be able to name at least some synonyms because it's very important. It characterizes this condition. Bronchopneumonia means that this type of pneumonia is always connected with bronchus. And here we can see wall of the bronchus, smooth muscle layer, epithelium, ciliated epithelium of bronchus, and you can see that all the wall of the bronchus and adjacent alveoli are infiltrated by neutrophils. You can see this in the lumen of the bronchus, in the wall, and in the alveoli. And this type, there is suppurative inflammation. Focal pneumonia means that not the whole lung and even not the whole lung lobe is involved. And usually foci can be numerous and they go correspond, they go with branching of the bronchi. So when in Lobar pneumonia we have involvement of the whole lobe at the beginning, in this process it's important that it's very focal. Here you can see these focal changes. For example, here this is just one focus of very dense infiltration. In here you can see that this is quite clear. In Lobar pneumonia it's different. First of all, you can see that this picture is more pink than the previous one, because in Lobar pneumonia there is fibrinous inflammation. You should remember that fibrinous inflammation can be of two types, Croup and diphtheric. And here we, of course, have Croup inflammation. Lobar pneumonia is the same as Croup pneumonia, and sometimes you can need also the name pleuropneumonia because we always will see pleuritis in this disease. Lobar pneumonia has 4 stages of development. So the first step is infiltration, when interalveolar septa here are infiltrated. When erythrocyte, when the blood vessels become dilated, erythrocytes come here, we call it infiltration. On the next step, red erythrocytes go into the lumen of alveoli, and on this step we call it red hepatization. Hepatization means that this lung is so dense as liver, is really it really reminds of liver, and sometimes can be mistaken by students when they see gross specimen. The next step after red hepatization is yellow hepatization, when erythrocytes are eaten by macrophages and neutrophils, and we can see a lot of hemosiderosis if you are attentive. And the last step is healing of the process, when resorption of this exudate, when everything disappears. And very important feature that you should see here is fibrin. Fibrin between all these cells, fibrinous exudate, because this is fibrinous inflammation. The next specimen is gastric ulcer. So ulcer is a very deep defect of stomach wall, deeper than muscularis mucosa. It's very important to differentiate between ulcer and erosion. And when you have this question on your exam or on your credit, teacher usually asks, what is the difference between ulcer and erosion? Erosion is a very surface injury. It doesn't reach muscularis mucosa. When muscularis mucosa is injured and deeper, there is ulcer. So ulcer is characterized by development of big amount of granulation tissue. Granulation tissue is rich in blood vessels. On the surface of granulation tissue, we can usually see fibrin with necrotic debris. This is fibrin with necrotic debris. Then we can see granulation tissue, and these are smooth muscle, because in this case, ulcer reaches muscularis propria. Muscularis propria should not be mistaken with muscularis mucosa. Here we can see schematically, here there is muscularis mucosa, and ulcer is a big defect, deeper than muscularis mucosa. This is fibrosis, In the acute stage of the ulcer, we see fibrosis, granulation tissue, fibrinoid necrosis, and necrotic debris on the surface. In a remission of the ulcer, we see only fibrosis and epithelialization, which can be seen on the surface. One more picture on the surface: fibrinoid necrosis, here pink masses, necrotic debris, a lot of some substances here, and granulation tissue, which is rich with blood vessels. Here there is a gross specimen. We can see a big defect in the stomach, and here there is a gastric ulcer in remission. We see epithelialization. There are different complications of gastric ulcers, for example, perforation, penetration, bleeding, malignization of gastric ulcer, which are connected with deep destruction of the gastric wall. The next specimen is suppurative or phlegmonous appendicitis. Here we can see epithelium of appendix, crypts, and in the lumen of appendix there is a big inflammatory infiltrate. So in the wall of appendix there is diffuse neutrophilic infiltration. It's very important that to call something phlegmona, we should see infiltration not only in mucosa like here, but in all layers of the appendix wall, in mucosa, in submucosa, in muscularis propria, in subserosal and serosal layers. When we see neutrophilic infiltration in all these layers, we can tell that this appendicitis is phlegmonous. When we see inflammation only in mucosa, for example, we can say that this is surface or catarrhal appendicitis. So it's a little bit different. Here you also can see crypts of the appendix and big defect. Here probably there is also ulceration and infiltration by neutrophils. Grossly, the specimen looks inflamed because it's increased adenomatous, reddish color, and also you can see complication of phlegmonous appendicitis. Here it's perforation. Here we can see perforation. The next slide is Echinococcus multilocularis in liver, and the quality here is not really good, but still here you can see this zone of parasite, which is surrounded by a zone of perifocal inflammatory infiltration, and at the periphery you can see atrophied hepatocytes, because when Echinococcus cysts can be really large, they can reach 20 or 30 centimeters in diameter, and of course they push on the cells which surround these cysts, and they can cause atrophy of these cells. The next specimen is trichinella in skeletal muscle. Trichinellas can be found in skeletal muscles as small circles which contain spirals, irregular shaped organisms here, and they can be also surrounded by infiltration, especially by infiltration with eosinophils. Eosinophils can be seen there when there are parasites, and these pink spots are skeletal muscles. The next specimen is miliary tuberculosis in the lung. Here you can see typical tuberculosis granuloma. In the center of tuberculosis granuloma, there is pink caseous necrosis, which is surrounded by a lot of lymphoid and epithelioid cells and a lot of giant multinucleated Langhans cells. So you can see Langhans cells are here. They can be easily seen even on low magnification. You can notice that zone of the lung which is adjacent to this tuberculosis granuloma has area of emphysema, because it's quite often complication of some obstructive processes in the lung, for example, of tuberculosis or tumors, because excessive air stays in the lung and leads to disruption of interalveolar septum. So this is typical tuberculosis granuloma, and you should be able to describe it. The next specimen is scleroma. Scleroma is also specific granulomatous disease, the same as tuberculosis. You should tell the etiology of scleroma. Scleroma is caused by Klebsiella rhinoscleromatis, or bacilla of Volkovich-Frisch, and here it involves the epithelium of upper respiratory tract. Here you can see non-keratinized squamous cell epithelium of trachea, and in derma you can see diffuse inflammatory infiltrate, which consists of multiple plasmacytes. Here you can see a lot of plasmacytes. Plasmacytes have oval shape with nucleus pushed towards the periphery, and you can see a lot of clear cells. These clear cells are very important here in scleroma because they are diagnostic cells. Diagnostic cells in scleroma are called Mikulicz cells, and Mikulicz cells are the same as macrophages with these Klebsiella rhinoscleromatis. So it's not any specific type of the cell. It's just macrophages with Klebsiella rhinoscleromatis. And sometimes in the cytoplasm of plasmacytes, we can see globules, like here, for example, I guess, which are called Russell bodies. These Russell bodies are abnormal accumulation of protein due to excessive work of plasmacytes, Russell bodies. Maybe it's difficult, but at least you should tell that there is excessive plasmacytic infiltration. Again, these are plasmacytes, and a lot of diagnostic Mikulicz cells. Mikulicz cells are macrophages with Klebsiella rhinoscleromatis. We will continue with the next slide. The next slide is hemangioma. Hemangioma is a benign tumor from the blood vessels. So here on the sample, we can see a stratified squamous cell epithelium, keratinizing, because you can see keratinization on the surface. And in the derma here, you can see diffuse proliferation of the blood vessels. You can see that all of them have different diameter, different size. Somewhere there are erythrocytes in the lumen of the vessels, but they look quite benign. If you stain these vessels by immunohistochemistry, you would see that all layers of the blood vessels are saved here, so there is nothing malignant, but this diffuse infiltration sometimes grossly looks like really not very smart plaques on the skin of red color. You can see it here. It looks a little bit like nevus, but it has red color because of multiplicity of these blood vessels. And this lesion is more characteristic for children groups because in adults they have tendency to regressing, and in children we can see them more often. Here you can see hemangioma on high magnification, blood vessels which have erythrocytes in the lumen, and you can see that there is a lot of stromal component between all these blood vessels, which are completely benign. The next specimen is non-keratinizing squamous cell carcinoma. In this situation, these are metastases of non-keratinizing squamous cell carcinoma to myocardium. That is why you can see myocardial fibers, myocardial here, and between these cardiomyocytes, you can see complexes of malignant tumor. These are solid complexes because you don't see any glands formation, you don't see any lumens, they are solid, and you should see that there are a lot of mitosis, a lot of proliferation here. Cells look atypical. We can see typical features of cell atypia. Nuclei are hyperchromatic. Somewhere there are nuclei, somewhere there are atypical mitosis. In this specimen, you should be able to tell the difference between keratinizing and non-keratinizing squamous cell carcinoma. For example, in this field of view, we see keratinizing squamous cell carcinoma because there are so-called squamous pearls. These pearls are rounded structures which tell us that this tumor has tendency to keratinization. Tumors that have keratinization, they are more differentiated, and that means that these patients have better prognosis, because keratinization means that these tumor cells are not completely dedifferentiated. When cells dedifferentiate, they lose their function. One of the functions of the squamous epithelium is producing keratin. So if these cells keep the capacity to produce keratin, that means that they are still not very malignant, but still these are complexes malignant, but they are just a little bit better in prognosis for these patients. So this, one more time, this is non-keratinizing squamous cell carcinoma because we don't see squamous pearls, and this is keratinizing squamous cell carcinoma because we see these pink squamous pearls. They consist of keratin. The next slide is gastric adenocarcinoma. So definition of adenocarcinoma. Adenocarcinoma is a malignant tumor of glands, particularly in stomach. And here we can see one piece of non-tumor gastric mucosa, because here we can see benign gastric glands. And here on the right side, you can see a big tumor which replaces all mucosa and grows into the deeper layers. You can see that this tumor consists of glands which have lumens. So as adenocarcinoma is a tumor of glands, when you see malignant tumors with a lot of lumens in tumor complexes, that means that this is adenocarcinoma. For example, on the previous specimen, where we saw squamous cell carcinoma, we didn't see any lumens because squamous cell carcinoma is not from glands, it was solid tumor. Here we see a lot of lumens. Besides, here we can see not only cell atypia, but also tissue atypia. That means that these tumors replaces all mucosa, and this tumor also produces a lot of mucin into the surrounding tissue. A lot of mucin you can see here, and some complexes have really irregular shape. Here you can see on high magnification very beautiful nuclei atypia. You can see that all nuclei are really pleomorphic. They differ in size. They have nucleoli somewhere. They have a lot of extracellular mucin. One of the types of gastric adenocarcinoma, which is not really similar to this one classic type, is signature cell adenocarcinoma. Just to know for you that there is a type of cancer when the cells look similar to rings, like jewelry, when the nucleus is pushed towards the periphery and there is a lot of mucin in the cytoplasm. This variant of gastric adenocarcinoma usually is associated with the mutation in a gene which codes E-cadherin. E-cadherin is a protein of intercellular contacts, and when there is a mutation, these cells just can't connect to each other. That is why they look not like glands, but like separate cells. And this type of gastric adenocarcinoma can spread really quickly. So the prognosis for these patients is usually worse. Just reminding that Grossly, gastric adenocarcinoma in most cases looks like exophytic tumor. That means that it grows in the lumen of the organ, and here you can see this exophytic component, irregular polypoid mass. And under this exophytic component, there is endophytic component, which grows into the gastric wall. This growth into the gastric wall tells us that this tumor is malignant, invasive, and it looks like ulcer. Of course, to know exactly that this is a malignant tumor, we should take biopsy from this lesion and to prove this under microscope. And the next specimen is rhabdomyosarcoma. First definition, rhabdomyosarcoma is a benign tumor of the striated masses. So this is a mesenchymal tumor, malignant mesenchymal tumor. Here you can't see any specific epithelial and stromal component because this is a mesenchymal tumor, and everything here comes from stromal components. So here you can see tumor cells which have very typical signs of atypia, hyperchromatic nuclei pleomorphism. So that means that all nuclei differ in size. Some of them are big, some of them are small, some of them have mitosis, and so on. Here you can see, for example, very big atypical mitosis. That means that this mitosis has no two poles of division as in normal condition, but three poles of division. And tumor has mostly spindle-shaped architecture. That means that tumor cells look like spindles. The next specimen is melanoma. So in the previous part of our discussion, we discussed benign nevus, melanocytic nevus, and here we have melanoma, which is malignant transformation of melanocytes. Here we can see stratified squamous cell epithelium. Here we can see keratinizing layer and epidermis, which is mostly replaced by this tumor. All of the field here is replaced by malignant tumor. You can see some pigment too, because melanocytes, even when they are malignant, they still can produce melanin. These cells without any melanin, they are also malignant melanocytes. I told you that when cells lose their differentiation, they sometimes lose their functions, so they can't produce melanin sometimes when they lose this function. And you can see that this tumor has diffuse spreading both in superficial zones here and in deep zones, because, for example, in nevus, we saw that there were nests of nevi cells on the surface under the between the epidermis and derma, and here we can see that even in deep areas of the slide, we can see a lot of malignant complexes. In your slide, when you will be preparing for the credit, you also can see such signs of malignant melanoma as invasion in the blood vessels, for example, which is 100% sign of malignancy. Here you can see as well tumor cells, which even injure stratified squamous cell epithelium, and which replace all this tissue. Grossly, we have one specimen, metastasis of melanoma in the brain, and we can see a brain lobe which is infiltrated. We can't see very clearly border between gray and white substance because of tumor infiltration, and somewhere we can see these black spots which correspond to the pigment of malignant melanocytes. The next specimen is quite easy. So this one is coronary artery atherosclerosis. I showed you this specimen when we discussed thrombus. Here you can see a wall of the blood vessel, and here there is a smooth muscle, here there is adventitial layer, and under the endothelium, between endothelium and smooth muscle, we can see quite a big atherosclerotic plaque. This plaque contains a lot of cholesterol crystals, some lipids. Lipids are not stained by H&E. That is why we see white spots in the regions where the fat are deposited. And we see also proliferation of fibroblasts, because you remember that one of the stages of development of atherosclerotic plaque is fibromatosis. Here we can see area which corresponds to endothelium, and intima is thickened, really thickened in this case too. The next specimen is ulcerative productive myocarditis. So myocarditis is an inflammation of myocardium. In this case, this is a chronic inflammation, because ulcerative productive tells us that this is infiltration consists of lymphocytes. Here we can see cardiomyocytes, these spindle-shaped eosinophilic cells, and between these cardiomyocytes you can see a lot of violet dots which correspond to lymphocytes. This interstitial inflammation is one of the chronic productive inflammations you learned in the first semester. This structure is just blood vessel, probably a branch of coronary artery. The next specimen is bronchial asthma with pulmonary emphysema. So here we can see a bronchus. This bronchus has typical appearance for bronchial asthma, because it has a very specific shape of the lumen. It looks like a star. A star, I mean, very angulated shape of bronchial epithelium. Usually, we can see such epithelium in people with bronchial asthma, because constant acute symptoms, attacks of this disease. Also, we can see that smooth muscle layer of the bronchus is hypertrophied, because we can see a lot of the wall, smooth muscle wall, is really thickened. Sometimes we also can see eosinophilic infiltration, and here we can see some single eosinophils, but really not too much. Besides, here we can see zones of emphysema. So emphysema is characterized by the loss of interalveolar septa, when we see really a lot of air space, but lung parenchyma seems to be lost. So in case of bronchial asthma, there is centroacinar emphysema. Centroacinar mechanism of emphysema development means that there is a constriction of bronchus. That is why some volume of air stays in the lung, pressure increases, and this air just injures interalveolar septa. This is why we see these injuries in lung. This is a mechanism of bronchial asthma, just to remind you that this disease has first type of eye hypersensitivity, and there is a cascade of activation of EGE, which participate in degranulation of the mast cells. First of all, when allergen comes to the body, for example, in upper respiratory tract, it's eaten by dendritic cells and presented to the T helpers, Th2 cells. Th2 cells then interact with B lymphocytes by interleukin-4. B lymphocytes, in their turn, produce EGE, which connect to the mast cells, and then produce interleukin-5 and also call a lot of eosinophils there. So in the first attack, it takes some time, to develop all this cascade and to cause the granulation of the mast cells. But when the person has second or third attack of bronchial asthma, this process is really quick and the patient can develop all symptoms of bronchial asthma really quickly. Here you also see a scheme of changes in bronchial asthma. So you can see that in normal airway, we see not so much mucus as in bronchial asthma. In bronchial asthma, there is a very prominent infiltration by eosinophils, by neutrophils. In lamina propria, there are really dilated blood vessels. Smooth muscle layer is hypertrophied, and there is a hyperplasia of glands which produce mucus. The next specimen is miliary tuberculosis of the kidney. Here we see one more specimen of tuberculosis, and here there are areas of caseous necrosis. They are surrounded by epithelioid, lymphoid, and giant multinucleated lung cancer cells. And here there are glomeruli of the kidney, which tell you that you are in the kidney, not in the lung, because tuberculosis can develop in any organ as well as in the kidney. And the last specimen of this part of our discussion is portal cirrhosis of the liver. Definition of cirrhosis. Cirrhosis is a transformation of normal liver architecture to regenerative nodules. So regenerative nodules are islands of hepatocytes which are surrounded by fibrous tissue, by connective tissue from all of the sides. Cirrhosis is the end stage of fibrosis. It's not enough when you tell that cirrhosis is extensive fibrosis, because it's not true. To sign out a diagnosis of cirrhosis, we should see an island of hepatocytes which is surrounded by connective tissue. In this island of hepatocytes, there is no preserved lobule architecture. That means that there is no central vein in the center. There are no portal tracts or triads in the angles. So this is lost architecture of the normal liver. And sometimes we use additional stains to reveal these changes. For example, Masson stain. There is a classification of cirrhosis by etiology and by the size of the nodules. By the size of the nodules, grossly, cirrhosis is divided into micronodular, when these nodules are less than 3 millimeters, and macronodular, when the nodules are more than 3 millimeters. And by etiology, it's classified as post-necrotic, portal, and biliary. And on the gross specimen, you can see a lot of nodules of different size, and you can see that all these nodules are separated one from another by fibrotic septum. The next specimen is liver in lymphoid leukemia. So leukemia is a malignant tumor of the blood cell precursors. And here we can see a liver architecture and diffuse infiltration of liver parenchyma by blasts. Blasts are tumor cells in this situation. Blasts are these cells precursors of the future blood cells, in this situation precursors of lymphocytes. And here we can see that these cells are really hyperchromatic, ugly. These cells are really larger than normal lymphocytes. For example, here you can see a size of the cell which is close to the normal lymphocyte, and here there is a blast and it's really big. So here you can see that blasts infiltrate liver parenchyma, sinusoids, they are everywhere here. And here you can see them on high magnification. Somewhere there are even mitosis. For example, this is a mitotic spindle, which shows us that these cells are proliferating. The next specimen is Hodgkin lymphoma. First of all, I would like to remind you how the normal lymph node looks like. Normal lymph node contains germinal center, mantle zone, and lymphoid follicles in the lymph node are surrounded by T cell zone. So this is a B cell zone, and this is a T cell zone. In normal lymph node, all these zones are really well separated one from each other. And in lymphomas, we can see malignant transformation of B lymphocytes in Hodgkin lymphoma of these structures of germinal B cells. Hodgkin lymphoma appears from the B lymphocytes of the germinal center, and characteristic cells of Hodgkin lymphoma are so-called RS cells or Rich-Sternberg cells. They are here. Also Hodgkin cells. Hodgkin cells remind Rich-Sternberg cells, but they are single nucleated. So in Rich-Sternberg cells, we can see two nuclei with a nucleoli, eosinophilic nucleoli, and in Hodgkin cells, we can see one nucleus. There are also lacunar cells. Here we can see lacunar cells, and there are also so-called popcorn cells, but the picture is not present here. On the slide with Hodgkin lymphoma, we can see that this infiltration reminds a little bit inflammation, and the other name for Hodgkin's lymphoma is lymphogranulomatosis. That tells us that it was historically mistaken with inflammation. In the early period of studying this disease, we can see a lot of inflammatory cells, mainly eosinophils, sometimes, of course, lymphocytes and RS cells. These are Rich-Sternberg cells. These are main diagnostic and specific cells for Hodgkin lymphoma. Here we can see a particular type of Hodgkin lymphoma, which is called nodular sclerosis. This is a cross specimen of spleen in Hodgkin lymphoma, and this spleen looks enlarged, and its parenchyma remind one of the stones, and in Russian we call it Porphyrovaya selezionka. So this is a special name for the cross specimen of Hodgkin lymphoma. And this specimen is also Hodgkin lymphoma. These are para-aortic lymph nodes, so these are groups of lymph nodes. And this is aorta. So this was a 9-year-old child. That is why this aorta is without atherosclerosis, and it looks almost normal. But lymph nodes are really enlarged. Normally, lymph nodes are not that wide, and they are maybe 5 millimeters in size. But here they are really big and dense. That means they are infiltrated by the tumor. The next specimen is primarily contracted kidney. You should remember that primarily contracted kidney is an outcome of two possible diseases. One main disease is arterial hypertension, and the other disease is diabetes mellitus. In both diseases, we can see high stenosis of the small blood vessels in the kidney. Because of this high stenosis, some of glomeruli are atrophied, and we can see proliferation of connective tissue on the place of this atrophied glomeruli. Some of glomeruli, they undergo hypertrophy because it's compensatory mechanism, and because of that we can see so-called granular architecture of the surface of the kidney, because somewhere there are nephrons which are atrophied, and somewhere there are nephrons which are hypertrophied, and these areas alterate, and we can see diffuse granular surface of the kidney. On the microscopical level, tubules of the kidney, primarily contracted kidneys, they are shrinking and atrophied. And on the picture, On the left, you can see, in contrast, kidney in diabetes mellitus. So in this situation, kidney it looks sometimes similar, but a very main difference of this specimen is that epithelium of the tubules is infiltrated by glucose, which polymerizes in glycogen in the cytoplasm of the tubules. That is why we see very clear color of cytoplasm of these cells. Here is one more example of primarily contracted kidney. You can see sclerosed glomeruli and hyalinosis of the small blood vessels. So hyalinosis of these small blood vessels is a reason for atrophy of glomeruli. The next specimen is extracapillary, or its synonym, rapidly progressive glomerulonephritis. Also, we use the name glomerulonephritis with crescent formation. So, crescents are these structures in the capsule of glomerulus. So, this is a glomerulus of the kidney. It's decreased in size because it's pressured by this crescent which was formed. So crescents consist of cells and proliferating fibroblasts and fibers. So sometimes they compose maybe just a part of the glomerulus. Sometimes they can really cause atrophy of these glomerulus, and not every glomerulus will have these crescents, but still most of them have. And if the patient has, for example, more than 80% of crescents in glomeruli, that means that this patient needs kidney transplantation sometimes. One more example how the crescents can look like. Here you can see glomeruli and crescents in the capsule of glomeruli. Patients in extracapillary glomerulonephritis can develop hematuria, gross hematuria or microhematuria. That means we can see erythrocytes in the urine in microscope. And gross specimen of extracapillary or rapidly progressive glomerulonephritis looks like here. The kidney is enlarged, and on the surface of the kidney we see something that looks like a lot of red dots. And this contrast between white surface and red dots, it was the reason to call this kidney big red kidney. And this is very specific look for extracapillary glomerulonephritis. The next specimen is chronic pyelonephritis. Here we can see that parenchyma of the kidney mostly atrophied because here there are glomeruli which are completely sclerosed. So reminds of primarily contracted kidney. We don't see normal structures of glomeruli, they are sclerosed. Here we can see lymphoid follicle formation, which is very typical for chronic inflammation, and diffuse infiltration by lymphocytes. And the most important feature of chronic pyelonephritis is the so-called thyroidization. So these are kidney tubules, and these kidney tubules contain a lot of protein inside, and all this situation reminds us about thyroid structure. So you really can mistook this parenchyma for kidney sometimes. So it's important to be really attentive, because you should attentively look for glomeruli to prove that this is a kidney. And if you see these regions in the kidney, that means that this is chronic pyelonephritis, not thyroid. The next specimen is thyroid gland in Graves' disease. So Graves' disease is very interesting. One, it's example of hypersensitivity of type 5. And here we can see a scheme of pathogenesis of this disease. So In this condition, on the surface of the thyroid sites is thyroid stimulating hormone receptor, and this thyroid stimulating hormone receptor is connected by antibodies against this receptor. So in this situation, thyroid stimulating hormone can't interact with its receptor, and in these situations thyroid sites are constantly stimulated by these antibodies. And colloid, which should be present here in these follicles of thyroid gland, is almost absent, because thyrocytes are always stimulated by these antibodies. They are connected all the time, and colloid goes on in producing thyroid hormones. So here we can see that epithelium of thyroid gland is really high, so it works all the time. That is why it's in hyperplasia. Sometimes we can see some papillary projections in the lumen of the thyroid follicles, and the colloid is absent, because thyroid produces hormones all the time here, and that is why colloid is almost absent. One more picture. Sometimes colloid is still present, but it has so-called bubbles on the periphery, which means that colloid really fastly disappears. The next specimen is diabetic glomerulosclerosis. This specimen is very similar to primarily contracted kidney. The difference is that in the cytoplasm of the tubules, we have glycogen, because in patients with diabetes mellitus, there is a high level of glucose in the blood. This glucose goes also into the urine, and during the process of reabsorption, it goes in the cytoplasm of proximal tubules of the kidney. There, glucose polymerizes in glycogen, and glycogen stays here. Cytoplasm of the cells looks foamy, and glycogens also don't stain on H&E. That is why we see a white color. To reveal this glycogen, we should use special stain, periodic Ashev stain or PAS stain. You can also meet such name. And grossly diabetic glomerulosclerosis will look like primarily contracted kidney, as well as arterial hypertension. The next specimen is kidney in septicopia or embolic purulent nephritis. Kidney in septicopia is one of the forms of sepsis. Other forms of sepsis are septicemia and septic endocarditis. So in the old classification, you also can meet chroniocepsis, but it's really not so popular today, and it's better not to remind about it. In modern classification, you will not meet chroniocepsis. In this condition, in septicopia in the kidney, we see glomeruli. These glomeruli are inflamed, so we can see that blood vessels of glomerulus are dilated, and among these glomeruli we can see big infiltrates, which consist mainly of neutrophils, because these are abscesses. Here we can see one of such abscesses. We can see a focus of bacteria, and these bacteria are surrounded by neutrophils. The next specimen is purulent meningitis. So here we can see brain parenchyma, and on the left side we can see meninges or pia mater, and we can see that there are really dilated blood vessels because of inflammation, acute inflammation, and meninges are infiltrated by multiple neutrophils. Neutrophils are granulocytes, you can see them here. And on the gross specimen, the brain is adenomatous. We see dilated blood vessels on the surface, and we see a pus on the surface of the brain. This path creates a very typical appearance of meningitis grossly. And in this condition, you should be able to tell clinical forms of meningococcal infection. You should know that there is also meningococcal nasopharyngitis, for example, that there is meningitis, meningoencephalitis, that there is also the most heavy form, meningococcemia. And in this condition, there are also some specific complications. One of them is edema of the brain. When the brain goes into the foramen magnum, sometimes it's possible that the patient will develop stopping of breathing and heart beating, because the most important life centers are situated in the medulla oblongata. And in this situation, it can develop really quickly. And one of other possible complications is obturation of the holes through which liquor goes. And in these situations, there are possible complications as hydrocephaly, for example. And the last specimen of this part is focal cardiosclerosis. So this can happen after myocardial infarction, for example. And here we can see a big focus of connective tissue. This is a blood vessel. And on the periphery of this specimen, we can see cardiomyocytes. And cardiomyocytes here are hypertrophic because they can't divide, they can't proliferate. That is why their possible compensatory mechanism is hypertrophy. And it means that their cytoplasm is increased in size, but their amount stays the same. And as well here, we can see a focus of cardiosclerosis. And at the periphery, we see cardiomyocytes and their hypertrophy, not hyperplasia, because they can't proliferate. On the gross specimen, we see a focus of connective tissue. Here it is under endocardium. And this is a focus of connective tissue among the muscles of the heart. Now we will start with the last part of our slides for the discussion. And the next specimen is diphtheric angina or tonsillitis in diphtheria. So as you remember, we discussed in the first semester the topic acute inflammation, and one of the exudative inflammations we learned was a fibrinous inflammation. Fibrinous inflammation is divided into diphtheric and crupus. So diphtheric angina is a beautiful example of diphtheric inflammation. Here we can see tonsil. So this is number 2 here, is the necrotic lymph node in tonsils in diphtheria, and this is lymphocytic infiltration between these necrotic lymph nodes. On the surface of the tonsil, there is epithelium, but here it's almost destroyed, and in diphtheric inflammation, there are fibrinous deposits which are very strongly attached to the surface of tonsil. It's really difficult to remove them, and this is a big contrast with crupus inflammation, when these fibrinous deposits easily go from the trachea, for example, and can cause croup. The next specimen is liver lipofuscinosis or brown atrophy. So lipofuscinosis tells us that there is an accumulation of lipofuscin in the cytoplasm of hepatocytes here. Lipofuscin looks like yellow granules, and usually it's situated in the cytoplasm of the hepatocytes near the nucleus. You can also meet the name of this process as brown atrophy. It's believed that it was believed that this condition can be observed in old patients, and sometimes lipofuscin is called in the literature as wear and tear pigment. But actually, it can be observed in any age. In patients with a really high level of metabolism, for example, in patients with cachexia, when the organelles of the cells undergo a very quick metabolism, sometimes they're deposited in the cytoplasm in the appearance of lipofuscin. So lipofuscin is a fat-containing pigment of golden color. The next specimen is Hashimoto thyroiditis, and in this situation, there is a disease which is characterized by decreased level of metabolism of thyroid, and we can see dilated follicles which are full of colloid, and there is a formation of a lot of lymphoid follicles. So this disease is developed due to antibodies which produce to thyroglobulin and thyroperoxidase. Thyroglobulin and thyroperoxidase are components of colloid, and when they are produced, that means that thyroid can't make thyroid hormones from this colloid because thyroglobulin and thyroperoxidase are destroyed, and colloid accumulates in the follicles and doesn't participate in hormone production. And this is a very beautiful contrast with, for example, Graves' disease, because there we saw that epithelium was very high because thyroid worked all the time in this disease. And here epithelium is flattened and almost invisible, because in this situation thyroid doesn't produce hormones. And here we see lymphoid follicles, which is a very characteristic feature of chronic inflammation in this disease. Again, thyroid follicle, a lot of colloid, and flattened epithelium. The next specimen is a kidney in cytomegalovirus infection. So this is a kidney, and you can see glomeruli. Here are glomeruli. Here are tubules, normal tubules, and here are tubules which are infected by cytomegalovirus. Cytomegalovirus acts similarly to other viruses. It involves nucleus, and you can see that nuclei has a very specific appearance here. They have nucleoli, which are surrounded by so-called halo effect, clear zone which surrounds the nucleus, and cells become really enlarged here, and there is a so-called all-eye appearance of these cells. So these cells resemble a little bit an all-eye. That is why we call it in Russian also saviny glass, if it will be more clear for you to understand. So this is again cells which are affected by cytomegalovirus, nucleolus, which is surrounded by halo effect, a clear zone surrounding the nucleolus, cytoplasm, which is enlarged. And you can see here glomeruli. The next specimen is hyaline membrane disease. Hyaline membrane disease can be met in children with insufficiency of surfactant synthesis, and these children can't breathe when they are born because of insufficiency of surfactant, and they develop so-called hyaline membranes in the lungs because of hypoxia and massive producing of fibrin in the lungs. Here we can see lung parenchyma, which contains almost no air, and clearly seen hyaline membranes. They are really thick here, and you can see them. You can see that they consist of no any cells. They consist of fibrin, which is attached to the lung parenchyma, which is airless in this situation. The next specimen is liver in hemolytic disease of the newborn. This disease can be seen in this in children which undergo conflict between RH system of mother and fetus in period of pregnancy. So in this situation, antibodies of the mother go into the blood circulation of the fetus and destroy erythrocytes. And due to massive hemolysis, a lot of foci of extramedullary hematopoiesis can be seen in different tissues of the newborn. For example, here we can see liver, and we can see liver parenchyma and a lot of areas of hematopoiesis. These areas also contain blasts. That is why this disease can be sometimes mistaken with our another slide, leukosis, leukemia, but here we see that these areas are not so prominent. Not all sinusoids, for example, are filled with these blasts. And these blasts have a different origin, not only lymphoid origin. These are erythroblasts, myeloblasts, lymphoblasts, and others. Again, you can see a mixed population of blasts, erythroblasts, myeloblasts, and lymphoblasts. The next specimen is spleen in listeriosis. Listeriosis is inherited infection, and it can appear in the body by a formation of granulomas in multiple organs. And here we can see granuloma, which is fulfilled with listerias in the spleen. The next specimen is kidney cortical necrosis in disseminated intravascular coagulation. And here there are dead glomeruli which don't contain any alive cells. For example, this one looks normal, but these looks like necrotized and with a lot of hemorrhages. And there are also tubules, and nuclei can't be seen. That means that these tubules are also not alive. And the next one is polycystic kidney disease. Polycystic kidney disease is an inherited condition in which we see cystic transformation of tubules of the kidney. So collecting tubules, proximal and distal tubules sometimes. And here we see almost normal glomeruli, but all collecting system of the kidney is transformed into the cysts, and again cysts and flattened epithelium. And grossly this specimen looks like this one, like spongy kidney enlarged, and all the parenchyma consists of multiple cysts. The last specimen for our credit is breast cancer metastasis to the lungs. So here we see a lung parenchyma on the left and areas of metastasis. These solid complexes are complexes of breast cancer. These complexes infiltrate lung tissue, and here there is a non-tumorous lung tissue. On the high magnification, you can see that these complexes contain clearly seen signs of atypia, hyperchromatic nuclei, zones of necrosis and inflammatory infiltration, a lot of mitosis. So this was our last slide. I wish you good luck on your credit, and I hope that everything was clear for you.